We went through this in the week, and there was just two real things that really sprung out to me. And I'm a very simple soul. I'm not as academic as my august colleagues who you've been hearing speak to. I'm a very simple soul. But there were two things that really kind of sprung out to me. We don't really take into account chronic kidney disease and smoking in terms of our risk assessment of patients with atrial fibrillation. But it's quite clear now from the Garfield data that these are really important risk factors for adverse outcomes, and not just stroke, but overall mortality. What also has come out from the presentations that you've heard is that the CHA2DS2-VASc score is associated with all forms of risk. So we currently use it in terms of assessing stroke risk, but perhaps it's actually a better predictor of bleeding risk. And what's kind of weird is that female gender and hypertension don't seem to be as important as we previously thought. And all I can kind of throw out to you is that perhaps we are now treating women better for their underlying cardiovascular risk factors, and perhaps we're treating hypertension better. But that's just my own thoughts. I have no idea why they're coming out in Garfield as less important than they seem to be previously. However, when we look at the current risk score that we have for stroke risk, CHA2DS2-VASc, this was actually only developed on around 1,000 patients in the Euro Heart survey. And there have been previous indications that chronic kidney disease is important. And indeed, if you look at the small print of CHA2DS2-VASc, you are supposed to get half a point for having chronic kidney disease. But perhaps it's time that we took that more seriously. And that's really all I've got to say, is that they're the two striking things for me currently from the data that's been presented today, that CKD and smoking seem to be much more important than we've previously given it credit for. I'm not allowed to say that we ought to be looking at developing our own risk scores, but I've just said it. But it may be important that we use the real-life data that's accumulating through Garfield to start to look at what's really important. And maybe we're even looking at the wrong outcomes. We've been focusing on stroke, but as we've seen, the biggest problem with having AF is that it kills you. Thank you very much.
David, thank you very much indeed. We're going to hear from Professor Turpie, and then we can open this up for more general discussion.
Well, thank you very much indeed, Professor Caker, colleagues. It's a pleasure for me to join you here in London. As you've heard, registries such as Garfield are assuming much greater importance in our assessment of the management of patients with common disorders such as atrial fibrillation. I think one of the questions that we all want to know is, can we translate evidence from clinical trials into clinical practice? And I think that the Garfield registry, as others, will go a long way in helping us do this. I think the key things and the observations that have been made so far in this symposium is, and I think very importantly, anticoagulant treatment has a significant effect on outcomes, especially mortality and stroke. And as you can see from the figure, as emphasized by Professor Kam, there appears to be less of an effect in women than in men. And that is a challenge to us to try to determine why there is less of a response in women than men. I remember many years ago, it was stated that women don't respond to aspirin. Now, there might be some sense in looking at that again, because as you know, many of these patients receive aspirin as a prophylactic measure. One of the key observations, of course, was that mortality was greatest in the first year. And again, I think that reflects reality. It is not so in clinical trials, but we'll have a discussion why are they different from the observations made in a registry. And this comes to the last point here, that the patient populations are different in clinical trials than they are in registries. And indeed, when you look, I think one of the key things is that many of the patients in the clinical trials are not anticoagulant naive, whereas it is likely in a registry such as Garfield, where they are new onset patients, most of these patients will be anticoagulant naive. As pointed out by Professor Haas, INR, time in therapeutic range, has a very important impact on outcomes. And that's something we have to pay attention to as clinicians. Now, what is the thinking about currently? Now, let's go to the third item here. International guidelines recommend an INR of 2 to 3. And the NICE guidelines state that a TTR of less than 65 indicates poor anticoagulant control. Many of the studies that are done currently use retrospective and prospective strategies interchangeably. And I think they're different, and they will result in different outcomes in the clinical trials. The conclusions that we can come to is that I think very clearly the Garfield atrial fibrillation population, including now 40-odd thousand patients, are representative of clinical practice. We've seen that mortality and stroke rates differ from the clinical trials, and that is largely due to the fact that the populations are slightly different and that we are seeing the patients from the beginning with new onset atrial fibrillation, whereas in many of the randomized clinical trials, the patients have been on anticoagulants for some years before recruitment to the studies. It is clear from our observations that in practice, anticoagulant control is generally poor. And it varies from one part of the world to another, but a TTR of more than 65 was infrequently observed in the Garfield population. This means that many of our patients are being inadequately treated, and that is a key message that I have to put across to you. One way of overcoming this is to use a new anticoagulant drug because they are much more stable in terms of their anticoagulant effect than vitamin K antagonists, and as you know, they do not require anticoagulant monitoring. The Garfield registry is ongoing, and we will be able to give you much more information in the future, and from that data, I think we'll be able to persuade clinicians to improve the management of patients with atrial fibrillation. Thank you very much.